Because right in the middle of it, we had the HIPAA violation of
talking about the patient.
The patient, who's coming in. Yeah. So welcome to all of those joining us online. We're doing pigmented lesions this morning. So Nicole, you want to start us out? First off, at scan, that's just a fibrous tract remnant down here for a hair follicle. So what you see at scan is absolutely nothing, right? So let's go. So anyone who was saying, "Oh my God, I don't see anything," that's okay. But what do you see at higher power?
Once you get a little closer, you kind of see some dendritic cells that have some pigment in them. So
and their orientation
is parallel to the epidermis, so east to west.
So all east-west in orientation, pigmented dendritic cells, and
they look like they're mainly in the upper half.
Yeah, so they're upper half to third, not so many down deep.
So I would think one of the dermal melanoses, like the nevus of Ito or Oda or something like that.
Exactly. So nevus of Oda, nevus of Ito, nevus of Hori. So what's a Oda's nevus look like?
That's the one that's on the face, kind of in the trigeminal distribution.
Yeah, exactly. So it looks like those dogs, white dogs with big black spot over their eye. That's nevus of Oda, and nevus of Ito
is typically over the shoulder.
Yeah, kind of right here, and the Hori's nevus.
I think it can typically be either of those two places. Isn't the face more common?
Yeah, it tends to be acquired and bilateral. So it's like an acquired bilateral Oda's nevus. So that's exactly right. And then there are, big Latin names, Fuscus aurelius, Acromiodeltoideus, and things. And Oda and Ito is fine. And how does Mongolian spot look different?
The Mongolian spot is usually the bottom half of the dermis where you have all the...
So it's just deeper. So it looks the same, except the pigment tends to be deeper, and it's kids on the backside. Okay. So should we just go around?
Sure.
And I'm still learning.
That's okay. I'm Paige.
Hi, Paige.
So it looks like there is some melanocytic proliferation along the epidermal junction, but I also see some...
Yeah, a little bit at the deep junction.
Kind of scattered down below in the dermis.
Yeah, it's kind of a busy dermis, right?
Yeah.
Hello.
I don't really feel like I'm getting the dendritic appearance.
Yeah, definitely not dendritic. So then when you look at them, are they all the same? We got a smudge on that one. So here we go. A little higher where we can focus here. So are they all the same, or do you have a mix of cell types?
Oh, you definitely have a mix of cell types.
Yeah, with some of them being spindled as well as epithelioid.
This is just spindle nevus.
So it's probably a combined nevus when you have two cell types. So first off, at scan, the cells become smaller and disperse into single file at the base. That's all good, right? There's nothing that seems to be pushing collagen bundles away. It's not a bossy lesion that's pushing things out of the way. So that's all nice and seems like a nevus. And then you got a mixed population of large spindle and epithelioid cells as well as small cells. So probably a combined banal spitz.
Okay.
And the spitz component is intradermal, so you don't have the pseudoepitheliomatous hyperplasia and all of those things that you get with a compound or junctional spitz. So the hyperkeratosis, acanthosis, all of that you lack with the dermal spitz. Okay, Kendall, what do you see here?
So the epidermis looks
very pink, maybe some pigment down at the tips. But
Okay.
then really in the dermis, it's kind of busy. There's a lot of pigment. It doesn't really seem to be maturing very well,
Yep.
kind of going into fat.
And when you get down to the base, see how they're long, parallel theques, parallel to the surface?
Mm-hmm.
That's always melanoma
Gotcha.
when you see that.
Mm-hmm.
So, in contrast to the last one, which matured, dispersed nicely into single file at the base, this remains nested at the base, which is bad in anything except a blue nevus. Blue nevi have a bulbous outline. Looks like Mickey Mouse's finger pushed down into the dermis, right? Big bulbous outline. Doesn't disperse at the base, but difference between melanoma and blue nevus. You will never see a parallel theque pattern in a blue nevus. That's a melanoma pattern when you see that. Also, when you look at the stroma, blue nevus produces its own non-refractile stroma, and melanomas tend to trap pre-existing dermal collagen. So one of the things you can do is you kind of do the poor man's polarization. Look at the polarization in the middle and then away from the tumor at the edge. It's kind of the same in this one, right?
Mm-hmm.
Whereas a blue nevus is all dark in the middle.
Okay.
So, that's just a little check. It costs you nothing. It's just your hand. It takes 2 seconds. And it gives you a look at what the stroma is like. And it's not 100%. Nothing is in medicine, but it's pretty good, actually. Most new blue nevi just black out when you do that, and most melanomas remain bright and refractile. So, okay. So, little architectural features there. Okay, well, we got a few air bubbles there, but let's look at center here. Tiffany, what do you see?
Seeing some. There's definitely something in the dermis. It's like
Agree.
spindly looking.
So spindle, and does it break up into individual cells, or does it remain like in big theques or nests at the base?
It's remaining together.
And are they parallel theque pattern, or is it one big branching thing?
One big branching.
And then one trick that you might do is you might sort of go back to scan and kind of do your hand there. See how it blocks out?
Yeah. So I would say this is some type of blue nevus.
Yeah, exactly. So that just gives you a nice, by comparison, that's a blue nevus. And at a glance, when you're scared about them and you're having trouble, I don't know if the stroma is just trapped collagen or newly synthesized, that helps, because the blue nevi tend to black out. And they don't mature, and they don't disperse, and they don't have a gradient with H&B 45. That's just their nature. Okay, you're going to have to help me. You are...
I'm Rachel.
Rachel, yes, and you have introduced yourself before, so please accept my apologies.
So we've definitely got some sort of melanocytic proliferation in the dermis. There's some pigment scattered throughout. It doesn't quite look like it's maturing to me.
So when we look at it, I'm not sure that those cells are much larger than these cells, and it doesn't quite break up into single file. It does have a mix of dendritic melanocytes and non-dendritic melanocytes, which suggests that it may just be a combined nevus. It's got sort of a patchy perivascular, almost the way a lymphoid infiltrate would look around a vessel, and interstitial pattern, which suggests it may just be a congenital combined nevus. So what things might you do to confirm that it's just a congenital combined nevus, not a melanoma? Sorry.
just going to keep doing that until I answer it.
Okay. Well, if you
Yeah.
need to.
No,
we can
it's just the morgue texting me about autopsy.
Okay.
But, you could stain with HMB 45. See if there
Yeah.
was a
So
gradient.
HMB in a blue nevus, you don't expect a gradient. In an ordinary nevus, you do expect a gradient. If this is a combined banal blue, what you'd expect is one population will have a gradient, and the other one, the blue population, won't have a gradient. Okay, so you just have to look at them separately. The blue won't have a gradient with HMB 45. The banal population will have a gradient with HMB 45. You could also do a Key 67, which looks at cell proliferation, usually less than 10% for benign lesions, usually greater than 10% for melanoma. You can...
Now, does that hold true for pediatric populations?
It actually does, even in the pediatric population. In pediatric lesions and traumatized lesions and things like that, you may have more mitoses high, but seldom deep. So 5% deep, 10% overall is usually badness. And if you look, if you're looking for high power field, if you're finding more than one mitotic figure, that's certainly trouble. And studies have looked. Some nevi do have mitoses. So if you look with PHH3, you have to get up around 6 before it's really you're 100% in the melanoma category. But certainly atypical mitotic figures, deep mitotic figures are more worrisome with that. And this, with the fairly bland cytology and the patchy perivascular interstitial pattern and the combination of dendritic blue and ordinary banal nevus, I think this is just a congenital combined banal and blue.
Can you do that for us?
Sure. What you'd expect is you're going to have a funny mixed pattern here, right? Because it's combined, and you're going to have some collagen that's refractile there. It shows up better at 2x. So if you look there, most of the darkness you're seeing is just the cellular population, but you still have some trapped collagen in there, maybe some dark collagen that goes with the blue nevus, but kind of a mix, which is what you'd expect. Okay, David, we just read them. We have no control over how deep a specimen they give us.
That's right. So it looks like we've got sort of a sprinkling of melanocytes along the epidermis. I'm not really appreciating, there is some pigment in the dermis, so could be some melanocytes down there.
Yeah. And in fact, if you were to stain it, every one of these spindle cells, every little round cell here, which is just a spindle cell cut in cross-section, and all the spindle things, they're all melanocytes. So, worried, not worried, what would you do next? And of course, you don't see the base, right? So
so not seeing the base is sort of a...
And most melanocytic lesions that we get in the lab are shaped. So you don't see the base, right?
Yeah.
You don't see the sides, you don't see the base.
Yeah, so I think I would probably stain this myself just to see if there's, like HMB, to look for the gradient, look at MIB.
Yeah, and those things certainly wouldn't be wrong. One of the other stains that's very helpful to us is elastic stain. With the exception of desmoplastic melanomas and a few others, the vast majority of melanomas push everything out of the way to include elastic tissue, whereas nevi, all the elastics retained. In this case, our H&E stain picks up the elastic beautifully, so we don't even need an elastic stain. We can see it's retained all through. That's very strong evidence that this is a benign nevus. And with it being spindled, we wonder, is it kind of a variant of a blue? So let's go all the way down to 2x and throw our little hand in there. maybe hard to tell, but I'd say there's sort of a dark wedge in the middle there, consistent with a blue nevus. So with those things together, I'd probably on H&E call this one a blue.
Okay.
Would it be wrong to do the stains? No. When do you get a stain in pathology? When you wonder if you should have. That's basically it, right?
So this has population of cells in the more superficial reticular dermis.
Okay.
And then little area of slight separation, and then nests of cells maturing down into single cells at the base. It has involvement of the rectopylian muscle or nerve and kind of
so when it's
type pattern.
Exactly. When it's in vessel wall, in erector pili, in nerve, it's a congenital nevus, right? So we got congenital nevus, and then the question is, did anything bad happen in this, or is this just a normal congenital nevus? I see some large hyperchromatic cells. What does that mean in a neurocrest lesion?
Not much.
Not much is the answer. So in smooth muscle lesions like symplastic leiomyomas, and in neural crest lesions like neurofibromas and melanocytic lesions, atypia by itself in the absence of mitosis and expansile growth pattern means nothing. So malignant lesions are usually hypercellular, push things out of the way, have mitoses. Benign things commonly get ancient atypia if they're neural crest or smooth muscle, but it doesn't mean anything. So overall, probably just congenital nevus. Very good.
So a pretty massive proliferation of pigmented cells, likely melanocytes.
Yep.
And going at the top, there's certainly very well-defined nests, and as it gets deeper, it becomes just sort of diffuse population of cells, and they don't really seem to mature per se.
Yeah.
And they don't really singly disperse.
So any benign lesions that could look like this?
Certainly just a blue nevus.
Yeah, or even just a congenital nevus around the hair follicle. So those things would be benign that could have this architecture.
It is well circumscribed, side to side, sharply circumscribed.
How about gradient of pigment?
It's very benign appearing.
Yeah, pretty good. Now you do see a little bit here, but that pigment you got to go out from the follicle to judge its depth. So, if it's a similar distance out, and this is an oblique cut, so it's going to alter a little bit, compared to the distance down from the epidermis, then that's okay. So
this would probably be a good one to get a Key67 on, just to make sure it's reassuring. It's
wouldn't be wrong. You can also throw your hand on there. It does have some blue features in terms of the stroma. So, for that to work, you have to see pink stroma, and that pink stroma has to be dark. If it's solid cells, it's going to be dark when you put your hand in. So what you're evaluating is the bits of pink stroma in there. Are they dark or refractile?
So we're pretty bland, and there's some neurotized areas.
Yeah. So bland and neurotized, pretty reassuring, suggesting the whole thing probably is just a congenital nevus. And it may have some, it has some sclerotic stroma. There may be some blue element there in addition to banal. There are lots of combined nuclei. Oh, the other thing to look at in here, let's see if we can find a good example. Let me look around. I don't want to spend too... No, I can't find it. This one was cut. Right in here. You see a few. See how these things almost look like sebocytes?
Mm-hmm.
That's it's just swelling of melanosomes. It's a degenerative change similar to a balloon cell nevus. So it looks very much like a sebocyte. You tend not to have a scalloped nevus or a scalloped nucleus, but not all sebocytes show a scalloped nucleus. People have quipped that this is, quote, a nevus sebaceous, which is, it has nothing to do with nevus sebaceous aviatus, but it's completely benign when you see it. You see it, well, actually, that's not what I meant to say. What I meant to say is it's meaningless when you see it. You see it in nevi, you see it in melanoma. It doesn't tell you malignant or benign. It's just something that happens in melanocytes, in any melanocytic lesion. So it's just, that's that sebocyte-like change, means nothing. Got here. Presumably there's tissue somewhere. Maybe not that one. I wish we could choose not to read them when they look like that. Okay, how about that?
So off the bat, in the epidermis, I'm noticing some hyperkeratosis and kind of some epidermal hyperplasia, almost kind of pseudoepitheliomatous.
Yes,
in
spiky PEH-like hyperplasia of the epithelium.
And then I have some bigger nests at the DEJ that kind of look like they're running almost vertically along what's left of the rete. And there's some good clefting in those nests between as well.
Okay, so you're making a strong case for Spitz nevus. So what do you want to know about the patient?
I'd like to know the age.
That would be a really good thing to know, right? Because if this is a 5-year-old, you'd be on shaky ground calling it anything but a Spitz. And if this is a 90-year-old, maybe you better think twice about Spitz, right? Of course, the joke is in my practice, they're all 32, right? Right where it doesn't help. Because that's what people send me. Other things that can help, there are caminobodies here. To distinguish a caminobody from a dead melanocyte, which you can see in melanoma, throw a trichrome on it. It should stain like collagen, because caminobodies are lumps of basement membrane zone material. Other things that help. In a Spitz nevus, the orientation of the nest should all be pretty much north-south. They should be raining down or like hanging like bunches of bananas. If they are haphazard or there's a lot of east to west, that's trouble. That's what you see in spitzoid melanomas. They tend to be pretty much north-south in Spitz nevi. Spitz nevi end abruptly in a nest. They're sharply circumscribed. They do mature and disperse at the base. And if you just look at the silhouette, they look like a V or a inverted pyramid with the base of the pyramid at the top and the tip towards the bottom. Now this is kind of a broad lesion. But as they get bigger, the ones you worry about, they're still basically broad at the top, taper at the base. Spitzoid melanomas tend to be the opposite. So if you look, people have done studies where you look at these cases you agonized over, and if you just draw kind of a rough triangle around the outline, you categorize 90% of them correctly just by which way your triangle points. If your triangle points up, it's a melanoma. If your triangle points down, it's a Spitz nevus. So just some basic things that are helpful in the majority of cases, and you look at it and you say, Spitz, it looks like a Spitz, and a more experienced person says, that ain't a Spitz. What are they looking at? They're just looking at which way is the triangle pointing. Okay? And is it dispersing at the base? And are they vertically raining down or not? Benign Spitz nevi tend to be a mix of spindle and epithelioid cells. Young women on the legs and males on the back have purely spindle cell lesions. But purely epithelioid lesions, outside of the setting of a purely dermal lesion, purely epithelioid compound lesions tend to be melanoma. So spits are spindle and epithelioid cell, S&E nevus. Pure spindle cell variant exists. Legs of women, trunk of young men. A purely epithelioid compound spits-like tumor is probably melanoma. So you've got your V, you've got your dispersion, all of those things can help. In terms of immunostains, HMB does work on these. MIB is helpful in these. And another one that's helpful, S100A6, is strongly chocolate brown positive all through spits, nevi, weak and patchy, and melanomas. Caution when you get to the pigmented spindle cell nevi, those small cell ones that are all spindle cells on the legs of women and trunk of young men. They stain like melanoma, weak and patchy. Any small spit cell stains weak and patchy. It's the big spit cells that stain strongly with S100A6. So like with anything else, you just have to know your stain in order to use it appropriately. Okay, and then you would think I could remember your name for one rotation. Paige, thank you.
So it looks like we have a nodular type proliferation here. It's kind of obscuring the reedy. I think it's maturing.
So it does seem, they do seem to get smaller, and they do seem to break apart into single cells. If you were to draw a triangle around this, is the point of your triangle more at the top or more at the bottom?
I would actually say more at the bottom.
So, and point at the bottom, is that a good thing or a bad thing?
That's good.
No, that's good.
Oh, sorry. Yeah. We're good. Okay.
Point at the bottom is good. Point at the top is melanoma. So this is, distinctly broader across the top than it is at the bottom.
Mm-hmm.
It does tend to mature. It does tend to disperse. Does it end in a nest?
Yes.
Yeah, on this side, that side's undecided, right?
Okay.
This side ends in a nest. Relatively small, relatively well circumscribed. Are they raining down like bunches of bananas?
Yeah.
Yeah, pretty much.
Mm-hmm.
You have acanthosis only where you have a lot of junctional nests. It is effaced in some areas, which could raise concern. So look higher for mitoses. It wouldn't necessarily be wrong to do other stains. One really helpful clue, how big are your collagen bundles?
Pretty large.
I'd say pretty small.
Okay.
So those are pretty puny
Okay.
and pretty dark red. Adults have dull pink, broad collagen.
Mm-hmm.
Little kids have bright red, skinny collagen. This is kid skin when you look at it. So it looks like kid skin. And it's a triangle pointing down, and at least on one side it ends in a nest. It's small and well circumscribed. I'm not even going to get stains on this one. And this one I just call a spitz. If that were a 50-year-old, then we'll talk, right?
Okay, so I see some cells kind of scattered in the dermis.
Yeah, there's some things scattered in the dermis. Let's get a closer look at them.
It could be some of those dendritic melanocytes.
They're dendritic, and what directions are they going?
Kind of east-west.
Kind of east-west. Any thoughts?
So maybe like a nevus. Is this on the face or the leg? Or I guess.
Well, that would be a good question,
Yeah,
right? So,
nevus of.
if this is
Oda or
on
Odo?
if this is on the face, it's Oda. If it's on the shoulder, it's Ito. If it's bilateral on the face, it's Hori. It's one of those benign dermal melanocyte things.
So, right off the bat, there's definitely a lot of pigment along the DEJ.
Yeah, a lot of pigment along the DEJ. Are there melanocytes associated with it?
Let's see.
There are always going to be some, right? Are they particularly increased in number? Do you see a melanocytic proliferation?
I don't think so. But there are some bridging.
Yeah. Now, how about all of this pigment? Is that in melanocytes? Is it in keratinocytes? Any way to tell?
Gosh, I'd want to do a stain.
Well, you can always do a stain if there's a question. If they sit as little hats on top of the nucleus, it's probably a keratinocyte.
Okay.
Okay. Their melanin is evenly dispersed within melanocytes and clumped within keratinocytes. It may not be exclusively at the cap, but it kind of condenses to a cap
Right.
because it's like as a little umbrella protecting the keratinocyte nucleus, right? Like a sun hat,
sun hat.
exactly. Like, the baseball caps bald guys wear. So it protects your head from the sun. So that's, tells you it's probably, you could always do a stain for confirmation, but probably there's no significant melanocytic proliferation.
Okay.
That's all in keratinocytes. It's fairly sharply circumscribed. And is the pigment confined to the basal layer?
No, it's not.
In fact, there's a lot of pigment in the corneum.
Yeah.
Anything with pigment in the corneum looks black clinically. This would have been probably a red-headed individual with freckles on their shoulder, and then one freckle-like thing that looks like you can almost see through it, but it's jet black and irregular. They're called ink spot lentigo. So an ink spot lentigo tend to be redheads on the shoulder, jet black, but jet black can almost see through. So you get the sense it's a thin lesion. So the clinician took it off, didn't really think it was melanoma because the pigment looks so thin. Looks almost like you could scrape it off, which you can a lot because it's in the corneum, right? And what you see is the sharply circumscribed basilar pigmentation all the way through to the corneum, but all within keratinocytes. So benign ink spot lentigo. Different from a solar lentigo, which has proliferation of the epidermis. So it looks like little Mickey Mouse fingers dipped into chocolate, right? That's what a solar lentigo looks like. How about syndromal lentigenes? Lentigo simplex. Just basilar pigment, nothing in the corneum. And those are the lentigenes that you get in the axilla and neurofibromatosis and in the central face and carnes, and you have leopard syndrome and Moynihan syndrome and all of these inherited syndromes where you have cardiac defects and lentigenes, and those are a lentigo simplex. They don't look like a solar lentigo, so no bulbous proliferation of the epidermis. And they don't look like an ink spot lentigo. No pigment up in the corneum. It's just basilar pigment. What does a labial melanotic macula look like?
Oh,
So,
it's got the
lip or groin?
Thick.
acon.
Yeah, so it's basilar pigment, but your redi aren't normal. They're not skinny little bulbous things like a solar lentigo. They're big, square, boxcar-like things, acanthosis of the epidermis. So they're recognizable. Okay. So, Rachel.
Alright, so I've got kind of, looks like some acanthosis and then some nests of
Yeah,
cells in
acanthosis,
the-
and it's kind of broad, right?
It is broad.
Not skinny little bulbous things.
Yes.
Do you know anything with big, broad boxcar-like acanthosis and basilar hyperpigmentation?
Could this be a melanotic macule?
It could indeed be a melanotic macule. And they look the same when they're penile or vulvar lentigo or labial on the lip, on the oral labial lentigo, they all look the same histologically. Okay, David.
Looks like we get some pigmented cells that are sort of perivascular. Seem to be hiding out along the vessels.
Yeah, and then the question would be, are those melanocytes or are those just melanophages?
Mm-hmm.
And when they're perivascular like that, probably just melanophage,
Okay.
right? How about at the junction?
And then at the junction, looks like we've got sort of a scattering of melanocytes.
So you-
I don't see any confluence, really.
So no confluence. You do have nests, and
Mhm.
are the nests beautifully, evenly spaced, all similar in size and shape, or do you have more of a syncopated Latin beat here?
They
That
might
nest-
vary in size.
Yeah, they vary in size, they vary in shape, they're not equidistant from one another.
Mm-hmm.
Great in music, lousy
Not
in
good.
melanocytic,
Yes,
right?
sir.
And do you see areas where you have non-nested melanocytes at the junction?
Yeah, there's some single cells.
Yeah, so you have a proliferation of non-nested melanocytes. You have nests that vary in size and shape that are not equidistant from one another. Do you have a normal reedy pattern, or is your
Well,
reedy
it's kind of
effaced?
effaced. Yeah, I'd say it's effaced.
So
I'm thinking like melanoma in situ.
So all of that suggests melanoma in situ. What if I told you a benign nevus had been shaved here about 3 months ago?
I'd like to see the original.
Yeah, you want to see the original. Could it be recurrent nevus? Well, if this is scar,
It's a good scar.
it could be recurrent nevus, right? How are you going to tell the difference? So I'll punt this one to the fellows. If we did an elastic on here, are you going to see elastic in the scar?
No.
Are you going to see elastic in the fibrosis of most melanomas? No.
No.
So how do you tell them apart?
If the confluence goes past the scar, that's a bad sign.
So if the melanocytic proliferation is fully confined to the area over the scar, that's compatible with recurrent nevus. If it extends beyond the scar, that's trouble. And how about in the elastic pattern itself? In a melanoma, you've got crushed elastic, snow plowed to the edge, whereas in a scar, it's just gone, and what you get is recoil at the edge. So instead of a band of snow plowed elastic fibers, you have thick individual fibers where a rubber band that was stretched out has now been snipped, so it gets thicker and shorter. So it takes a little looking at one versus the other to get comfortable with it, but you can't tell them apart. And the history there was that was a previously shaved nevus.
So you have a pretty small lesion. It's like they got around it with the punch biopsy. A lot of hyperpigmentation, really not really confined to the basilar layer, and then you have some melanophages. They're kind of scattered around the vessels, and also some in the stratum corneum. So probably this was a redheaded person with a tiny little jet black lesion consistent with an ink spot lesion.
Exactly. So it looks like an ink spot lentigo. And then as a twofer, what else do you have here?
They have some pittospore.
Or,
It's like really multigenetic.
yeah, or trichostasis spinulosa. So, you know, little retained vellus hair follicles in there, which is harmless. They look like blackheads over your shoulders, but they're harmless. A good one to do.
So pretty broad acanthosis with basal hyperpigmentation. Looks pretty good for like a nasal melanotic macule.
Yeah, so it looks like a melanotic macule, pretty broad, almost boxcar-like hyperpigmentation, pigment confined to the basal layer. One of the hints is you have a vascularized submucosa, lots of vessel, lots of nerve, delicate collagen. It's not a bundled reticular dermis, so you're on a mucosal area, not on skin.
So you've got a little bit of irregular acanthosis. There's some pigment in the dermis. From this power, I can't tell if they're just melanophages or if they're melanocytes.
And does your dermis look normal?
No, it looks a little fibrotic.
Looks a little fibrotic, sclerotic.
Mm-hmm.
If this were desmoplastic melanoma, any hints you'd expect?
Maybe some nodular lymphoid aggregate
Yeah,
or
exactly.
something over the top in the DEJ.
So if you're lucky, a little subtle lentigo maligna at the DEJ, but often you don't see it. In the dermis, nodular perivascular lymphoid aggregates, or that in any spindle cell proliferation buys you a SOX10 or S100, right, to rule out desmoplastic melanoma. We don't see either of those here. One of the other things you can do is let's go back to 2x and look. It seems undecided. I see some dark areas of pigment in there, so maybe we have some theeks of blue in there in that sclerotic stroma. Can't really tell. Let's go a little higher. What do
There's
the cells
definitely
look
some-
like?
Those guys look a little more epithelioid.
Yeah, more epithelioid. You know, any kind of purely dermal epithelioid nevus with sclerotic collagen?
I probably should.
Any spits that's desmoplastic?
How about a desmoplastic spit?
Yeah, exactly. So desmoplastic spits nevus, they tend to be purely dermal. They have large spit cells, either singly or in theeks and aggregates, and they have a sclerotic stroma. And they look like white fibrotic lesions. So the clinician didn't know what it was, but wasn't really worried about melanoma with it. You know, it's usually a avascular, pale, anemic-looking bump.
Is it with that variant spits? Is it usually also younger people?
It sometimes, but a lot of them are like young adults with desmoplastic spits. Whereas, spits lesions in a kid tend to be head and neck, usually pretty rapidly eruptive. Spits lesions in a young male or female tend to be pigmented spindle cell nevus, sharply circumscribed, dark brown, new lesion on a leg or trunk. And desmoplastic spits, it's not clear, were they around and no one paid attention to them until they turned into a hard bump, but they tend to be a lot of young adults in my experience. So, Nicole, where do desmoplastic melanomas occur?
I feel like
Where in the body?
Is it more trunk?
So occasionally trunk, but a lot of them face, a lot of them distal extremity. It's anywhere where you get lentiginous forms of melanoma.
Okay.
So lentigo maligna, which can be upper trunk, but a lot of them are face. So they grow out of lentigo maligna, acral lentiginous, mucosal lentiginous. What defines a lentiginous melanoma?
That you have more single unit melanocytes than you do nested.
And where do they tend to proliferate? What part of the epidermis?
In the basal layer.
Yeah, DE junction. So superficial spreading melanoma is buckshot scatter through the epidermis. Lentiginous melanoma, by definition, is predominant DE junction growth of melanoma, and that on sun-damaged skin is lentigo maligna, on acral skin is acral lentiginous. So not all acral melanomas are acral lentiginous. You have acral nodular melanoma, acral superficial spreading melanoma, But 90% of acromelanomas are sneaky little bastards that grow along the DE junction, and that's why it's called acral lentiginous. For acral melanomas, the rules are different. You don't see confluence usually. You don't see big nests. What you have is maybe in your big sizable biopsy, you may see 8 melanocytes if you're lucky. But they're hyperchromatic, they're angulated, and their arms are all different sizes. So they have this big pigmented dendrite here, this little dendrite there. They're weird. You know, big dendrites, little dendrites, angulated, hyperchromatic cells at the DE junction on acral skin. They don't belong there. It's trouble. What you're not going to see is you're not going to see buckshot scatter. You're not going to see confluence. I mean, maybe if it's really advanced, but what you got to look for are those angulated hyperchromatic cells with asymmetry of the dendrites. So they look different, which is why we give them a different name, right?
What's the difference between like lentigo maligna and melanoma in situ?
So lentigo maligna is a type of melanoma in
Okay.
situ. So there's superficial spreading melanoma in situ, there's lentigo maligna.
Okay.
There is acral lentiginous melanoma in situ. So lentigo maligna, what you expect is proliferation of non-nested melanocytes, horizontally oriented nests that vary in size and shape, not equidistant from one another at nexal extension, usually effacement of the reedy pattern, a flat-bottomed red fibrosis that pushes visible solar elastosis downward, displaces it downward. That's like the whole picture of lentigo maligna. Acral lentiginous, just associate that with the word sneaky little bastard, right? Because people miss them, and they miss them a lot because it's so easy. All you're going to see are those sneaky little angulated, hyperchromatic melanocytes, and instead of staying where they're supposed to be at the tips of the reedy, they're crawling up the sides of the reedy ridges a little bit. And their arms are all different sizes. The dendrites, big ones and little ones.
.slb, put a new dot for
Yes, .slb is absolutely correct. The other thing that can help with those is the degree of adnexal extension and sometimes crawling into the arches. Tips and sides of reedy is where nevi should live. If you remember, melanoma is your arch enemy. The arch is melanoma territory, right? Tip of the reedy, it sounds friendly. Sounds like you're breathing. Tip of the reedy to you, right? So tip of the reedy is good. Arch is your arch enemy, right? So those, fine at McDonald's, not good in melanocytic. Okay, how about this?
So I'm seeing pigment in the dermis.
And you are Paige. And you are Rachel.
Yes.
I am trainable. I may have forgotten by the next time we meet, but okay, go ahead.
Pigment in the dermis. I can't really tell whether there's any in the epidermis, maybe.
Oh, I'm sorry. Sorry, we're out of focus for those online. How did I do that? Let's get... Let me get refocused here. Okay, I'm sorry. Go ahead.
So there's pigment in the dermis.
Pigment in the
Looks
dermis.
like maybe some in the epidermis as well.
Yep. And there's definitely a melanocytic proliferation. I see one nest there. By and large, is it well nested?
Not really.
Not really.
There's some kind of creeping up. And
there is kind of creeping up, and then maybe you see some things in the arches. So, how big is this thing?
I can't really tell, but I mean, I think it's all taken care of.
Yeah, it's pretty small. right? So it's small and it's well circumscribed. So now there are a few possibilities. One is melanomas have to start somewhere, right? Two is there are poorly nested lesions that occur in young people, especially what's called the pagetoid intraepidermal Spitz nevus. They are relatively small epithelioid cells, so they're smaller than Spitz cells. They don't nest at all, or nest to not much of any degree, but they're small, they're well circumscribed, they're completely benign. You take any little piece of it and you can sucker most people into saying superficial spreading melanoma, especially if you put an immunostain, because they're all through the epidermis, but they're all uniform. They look like small Spitz cells. It's well circumscribed, and it's in a young person. And it's a recognizable benign entity. And this probably fits right into that. So you see lots of pagetoid scatter. They're not big Spitz cells, but they are epithelioid. They're kind of small epithelioid cells. It's poorly nested. It's at all levels in the epidermis, but it's a younger person, and it's small, and it's well circumscribed.
Do mitosis help you or not help you there?
Usually no mites, although you can get some because it's a junctional lesion. It's usually not sky high, but you can get some. We're describing different types of nevus, and it's important to know all the types of nevus. One of the things Dr. Ackerman used to ask his trainees, does what we're looking at look like any kind of nevus? If the answer is that looks like no kind of nevus, then it's no kind of nevus, right? And it's a melanoma. So you need to know all the different patterns of nevus, because the question is, can I fit this into any nevus that I know of? And if you can't fit it into any nevus, then maybe it's not a nevus. Good. What are we doing time-wise? I think we're right at the end. So we should stop there and sign off. And that's it for today.
Thank you.
Thank you very much.